Hey team, welcome back, and let's continue our conversation on chronic inflammation and its role in different forms of musculoskeletal tissue injury. Ooh, we're starting with a good one here. Factors that influence healing in fractures, a broken bone. You're going to go more in depth on broken bones in a number of other courses in this curriculum, but there is one area in which I want to talk about here. So there's a lot of forces that alter the healing pattern of a broken bone, and all of them relate honestly to the immune system and its function. So let's look at a couple of things here. And I want you to notice some patterns. So one pattern I want you to notice right off the bat is that there is absolutely a role in inflammation here. Okay, so smoking, diabetes, and anti-inflammatory medications influence the activity of the immune system. That's actually what's happening here. In addition, they alter physiology in a way that the immune system cannot work well. So for example, if you remember from our conversation how acute inflammation occurs, initially there's an increase in blood flow to a site, and look, nicotine actually alters that by constricting blood flow, right? So that's the opposite of what the immune system needs to get in there. Diabetes affects the way that the healing process occurs, in which collagen, there's not as much put down, it's laid down poorly, and the different ratios, the different types, remember there's dozens of types of collagen, the different types that are laid down, the ratios aren't, I guess what you could say, best. So in addition, diabetes also affects the health of your vasculature, which I don't have on here, but it prevents good blood flow if you just don't have enough capillaries going to a site where a bone is broken and healing needs to occur. In addition, anti-inflammatory medications, well, I mean, that's stopping the process full tilt. And sometimes that's the sort of thing where you have to come down to what am I trying to create here? Less human suffering or eventual good healing? And sometimes those you have to choose. I know that sounds terrible, but that's sometimes kind of a internal calculus that we have to sort with our patients. What sort of discomfort can they tolerate in return for maybe it will heal better? That's going to be different with each clinician and patient, but what you're doing is influencing the level of activity of the immune system, whether or not you take something like Advil or acetaminophen in high doses. These other bullets here still have to do with the activity of the immune system. You can think about, is there a concurrent soft tissue injury with the fracture, because that's going to mean more immune activity, right? Is there an interruption to the blood supply? In other words, sometimes we break a bone and vasculature is torn at the same time, such as like a trauma type injury. And then how are nutritional levels affecting fracture? Remembering that this is a very, very protein intense activity. And so the bony callus might not form as well if we don't have good nutritional intake to affect the levels of what the body can actually regenerate. Bone is actually really good at healing, fantastic at healing, right? That's in our list of structures where the cell can come back. It can regenerate and make a new bone cell, right? An osteocyte. But there are a lot of factors that influence whether or not that's going to go well, and that's what we're talking about here in terms of their influence in terms of the immune system's influence on that healing. Okay, let's switch over to muscle. So we've kind of come close to this with tendon and immobilization of ligaments and things like that, but let's get more deeply into it. So a muscle is injured in a phenomenon called a strain. So a strain comes in 3 levels, grade 1, 2, and 3. In 1, you don't really have fiber damage like you do in the other ones. So in grade 2, you have more fiber damage, and in grade 3, this is more severe, this is more complete disruption across the muscle. So remember that skeletal muscle is not something that can regenerate. So fibrosis has to occur to reconnect portions of muscle, right? So that's what's occurring here. And that's why this particular subtopic is important, because the strength of that scar tissue is not the same as the original tissue. In other words, you're only going to have so much expectation from a torn muscle as it heals. And that's something that's really tough. You might have to think about, okay, well then maybe the rest of the muscle needs to get stronger to compensate, right? You have to kind of work around the problem because again, the fibrotic healing which occurs after a grade 2 and grade 3 injury is not going to create the same sort of functionality as you had with the original uninjured tissue. Okay, so muscle immobilization, again, we're coming back to it, right? We talked about it a little bit with ligamentous, but here's another one. So you may remember from ex-phys that Wolff's law, I'm profound, right? Use it or lose it. In other words, a bone needs to have weight on it, it needs to experience gravity, or it will deteriorate. Same thing happens to muscle, and this is, again, one of the really strong physiologic expressions of this. An immobilized muscle will atrophy, and it will happen so fast. 6 hours into a state of immobilization, protein synthesis of your muscle fibers goes down. Yes, it is that fast, the same day. And within a day, you actually already start to get shortening of muscle fibers. It's kind of unreal how fast it happens, right? Let's think about a more extreme situation. In the ICU, in other words, a patient with critical illness, well, they're probably in the ICU for a non-muscle injury, is the truth, right? They're probably in the ICU for an organ system thing or something that's making them unstable. That's why they're in the ICU. Well, in this situation, you still have these secondary things that happen, and that's something we have to think about as PTs. Sometimes we're in the ICU to help a patient just prevent things from being so bad as they recover. We are not their primary provider, right? This person is not dynamically stable. Their vitals are not stable. That's why they're in the ICU. So we are not their most important provider. That's fine, because once we become their most important provider, they will hang out with us for much, much longer, and we will play a huge role in their lives nonetheless. But at the beginning, one thing we're thinking about is whether we can manage these secondary things like immobilization, atrophy. So what occurs on a cellular level to cause this to happen is dysregulated what we call autophagy. In other words, the body will eat up its muscle so that it can take that protein and spend it somewhere else. That's just the truth of it, right? In addition, mitochondria, your favorite intracellular structure, powerhouse of the cell, right? I swear, one of these days I'm going to get a t-shirt and just start wearing it with a blazer and slacks or something, and just says, it's going to have a mitochondria on it. It's just going to say powerhouse of the cell, because y'all just get so happy every time you get to say that. So just say it quietly to yourselves. Yes. Okay, good. Nicely done. Okay, so because there's so much inflammation, there's these high levels of sugar in a hyperglycemic condition, or hyperglycemic status, and then the immune system's going nuts, so you've got free radicals everywhere. Unfortunately, mitochondria are very delicate when it comes to free radical damage. If there is some sort of random electron, whatnot running around, mitochondria will get injured. So all of that is to say, none of these conditions are good for a healthy muscle, right? So you start to lose strength quick. So for each day that you are laying down in bed in an ICU situation, you lose 3 to 11% of your strength. That's right. Upwards of 11% of your strength to the whole body is lost for 1 day in the ICU. In fact, this is such a profound phenomenon that days of bed rest are independent predictors of decreased overall function during recovery. Yeah, so what if you're in the hospital for something like pneumonia? Let's say it gets really bad and you end up in the ICU. Pneumonia really needs you to get, your body really needs you to get all that junk up. But if you're not moving, it just compounds it, right? And now the very muscles that are letting you breathe are getting weaker. You can see how this becomes a snowball effect very, very quickly, right? It's this exponential deterioration and exponential worsening of a situation through lack of mobility. So much so that we are seriously some of the most popular providers in a hospital. I'm serious, we really are, because we prevent all of these bad things from happening due to immobility. Okay, so there's a famous study in PT. CSA there, that abbreviation is cross-sectional area. During the first week of critical illness, you will lose about 2% of the cross-sectional area to your rectus femoris every day. So rectus femoris is particularly important when we're talking about biomechanics, because of that muscle, your knee extension strength needs to be at least a 3+ in order for you to independently execute a movement of sit to stand. And if you can't sit to stand, we're not walking, right? So basically, what you need to consider here is that of all the different muscles like that really critical stuff, don't get me wrong, biceps brachii, it's losing about the same rate, in fact, slightly higher actually. But as a PT, for me, what matters is you getting up and walking, because that is your ability to prevent a lot of other conditions, which we'll talk about later. But basically, blood clots, pneumonia, all kinds of things, right? It just becomes this unreal multi-system snowball situation, all because you weren't getting up and walking. Well, maybe you couldn't because you have a critical illness, right? So what can we do instead? This is why me as a neurotherapist, my favorite early intervention is sit to stands. And I will make a patient work, because this is what I'm fighting. I'm fighting cross-sectional area loss. I'm fighting, look at this. Every 1% loss of rectus femoris thickness is a 5% increase in 60-day mortality. Right? So look at that, right? Like, it's happening right off the bat. So I'm not just fighting, muscle loss. I'm fighting to keep this patient alive in the long term. In the ICU, they're fighting to keep you alive at all, right? But I'm thinking ahead, like, oh my gosh, I need to keep you moving so that you don't lose all of this muscle strength in a critical area of your body so that you can stay alive in the long term. So if you end up on machine ventilation, in other words, something that's allowing your lungs to continue functioning, that's really bad, right? So the layman's term for that is being put on life support, right? When you hear that in a movie, oh, they're on life support, the odds are very good what they mean is mechanical ventilation, and the shorthand we'll use for that is the vent. So if you lose more than 10% of your rectus femoris muscle thickness at day 7, you are much more likely to remain on that vent, to have a longer ICU stay, and it's just a bad situation all around. In addition, you have other things happening, right? So you lose about 1% of your bone density too, but you're going to get a lot more conversation on bone density in your geriatrics coursework, but it's not as important in this particular conversation when we're talking about muscles. Bones are going to be, again, more of that long-term thing. So right now we're talking about the loss of muscle mass. So this is also why the National Council of Aging in COA there says that 1 day in the hospital means 1 week to recover, because it takes that long for you to rebuild your muscle mass, right? Do keep in mind that if you are critically ill, so there's kind of a difference between hospitals. So that's like the floor where you're a little more medically stable, like you do need to be in the hospital, it's bad, but maybe, your heart and lungs are working properly. But if you're in the ICU, it's possible to lose upwards of 15% of your muscle mass, muscle strength in 1 week in the ICU. 15%. Yeah, it happens so fast. So that's how you end up with more of this metric here. A day to a week is more or less the ratio of the rate of recovery that we're going to see. So that's my thing there, to get in some of that critical care musculoskeletal knowledge, right? Okay, so here's kind of a preview on an activity you're going to end up doing in class with me. So there's a new acronym. So we used to say RICE and then it was PRICE, right? The pressure and the icing and the compression and the elevation and all that. Well, we have a new acronym, okay? It's now peace and love. So I'm giving you a little spoiler for your second year. So you can see the acronym and all the different things that are listed out here. What I want you to think about right now, and you can do this during class, you can try to do it independently on your own, is think about on a cell level, on a patho level, why do we want to protect a joint? Let's say there's a tendon injury. Why are we protecting it for a couple days? Then why are we elevating it? Then why are we avoiding things like Tylenol? Why are we considering compression? Why are we teaching the patient about their injury? Why are we then later, or when should we really load that limb, right? We just talked about immobility, right? Why are we trying to keep the patient positive? Why are we making sure there's good blood flow? And then what is our approach to exercise? Because, we do need that, right? So this is kind of the new logic of what we do with an acute musculoskeletal injury of any type. And I want you to think about why what we've learned about here in this first unit in Patho influences why each one of these is a great idea. Okay, so what is the common sense logic of each letter? And I want you to spell that out for me in terms of cellular events. Okay, whew, that was a lot of ortho. All I do is brains. Oh my God, I'm just kidding. Okay, what we're really thinking about here, and I'll give you some of the answer to my earlier description of your activity that you'll do in class, is that everybody is a little different, right, in terms of their healing, in terms of their needs. And so what we're doing as PTs is we're considering all of this patho, and then we're thinking about what we need to do at each stage based on what's going on the inside. So our best choice for when to apply a concept such as, loading, let's get weight bearing. Well, it's not necessarily a number of weeks, right? We're actually thinking about what phase we're at on what is safe to do, because we need to move through the right phases to make sure things like collagen get laid down well, and collagen is getting laid down in its best behavior, and remodeling is occurring in its best way. That's kind of what we're looking at here, right? The patho really influences our ability to identify what phase we're at in terms of rehab so that we know what interventions we need to do. So here's just another slide here to give you a sense of what you're learning about and how it fits in once you're practicing. This is actually a slide from the AAOMPT conference in 2021, at which Dr. Nichols and Dr. Brummett presented. And look at the information they're showing here. All things that you just learned about, right? So when you go to conferences and you see this type of material, you know exactly what they're talking about, right? You know why inflammation results in pain, swelling, heat, and redness of joints, and why you have this triggering of chemicals, which is cytokines, right? And that's that early, moving into early chronic there, right? With your phases, thinking about why do we avoid NSAIDs, right? And we think about all the different components here. So this is just giving you a little taste of what's to come. The stuff that you're learning, I swear, it does actually play out as a clinician. And then here's some stuff that we'll discuss during class. And what it basically talks about is the balance between allowing healing to happen and then allowing recovery to happen in the same phase. So like promoting everything that's good, preventing bad things, and then getting function back as quick as you can, right? So let's think about something that we're going to do in class here about that osteoarthritis we talked about earlier. So this is a wearing away of cartilage in the knee. We're going to do the knee because that's the classic joint, right? The classic joint is the knee. Think about all the folks you know that have had a total knee replacement. So what happens at first? Well, that person is a little older. They notice an activity-dependent pain, feels a little less stable. Sometimes the knee seems to get kind of stuck, and there's intermittent swelling. What's going on the inside? That's what I want you to be thinking about. Years go by, and now the swelling is near constant with everything. And this is just with regular walking, not with running, with regular walking. So what has gone on the inside to explain what you see here, okay? That is a patient education thing you should be able to do even when you're done, more or less with your first year of PT, because we're teaching it to you right now. So what you're eventually going to do, and I have a blank space here so that we can draw in class, we're going to draw out what we're going to say, the different cellular events, and what all is going on. And to give you a sense of what we're going to be drawing, it's going to look more or less like this. So again, we're talking about something, a concept like tendinopathy or a concept like osteoarthritis, whatever the disease concept is, we're thinking about it and what occurred. Okay, so early we have this trigger. Later on, we have a failed healing process. And now here we are, our clinical presentation. How does our patho, which is here, explain what we're actually seeing, right? So that's what we're going to walk through during class, is making sure that we connect everything that we have done, an acute to chronic to super chronic, and specifically in different types of tissue, thinking musculoskeletal because we are PTs after all. How do we end up with our patients looking like they do? The types of pain they experience, the types of impairments they have. All right, team. Well done. I'll see you in class.